So essentially, folks, we're doing respiratory system. You need to know how to auscultate. You guys know what auscultate means, right? Listen with the stethoscope. So I'm going to be testing on these basic. Don't laugh at my drawings, okay? But I think we can all assume that these are what?
Lungs.
The lungs, right? The right one has how many lobes?
3.
And the left one has
2.
2 lobes, right? The heart's somewhere in here, right? What's this space in between the 2 lungs called? The mediastinum, okay? Which lung is going to be more susceptible to some type of respiratory infection?
The right.
Why the right?
More space. Yeah, no, wider.
Wider, okay. Well, there's more lobes. So think of it like that. There's more lobes, so we have to have more oxygen going to it. So the actual, they're thicker and they're shorter versus, they're really not that long and that narrow, but essentially that's what's happening, okay? If I say the patient's breathing in and out, okay, is that considered external or internal respirations?
External.
External respiration. What if I say that the patient's breathing in and out, oxygen exchange at the cellular level?
Internal.
Yeah, you got internal respirations, right? Okay. When we auscultate for respirations, what part of the lungs are we assessing? Where are we starting? What's it called?
The apex.
Yeah, the apex. So please recognize this as the apex. Okay, this is considered what?
Base.
It's considered the base. Whenever we auscultate, folks, we want to do the Z-track method. Okay, so the zigzag, excuse me. So you want to start there, you go there. So whatever you do to one side, you do to the next. If you're a clinical instructor, see you do this, that's incorrect. If they see you do this and then go down there, it's incorrect. The reason why we do the Z method is because we want to compare sides. So if this is sounding a certain way, if this one sounds the same exact way, that there might be, it might be okay. It might be this patient's baseline. Okay, if this side sounds clear and this side sounds gurgling or wheezing or something, then we're in trouble. Okay, we always use it for comparison. What is the sac that circulates the actual lungs? The pleura. Okay, so the sac is called the pleura. Okay, how many layers does a pleura have?
2.
Okay, it's got 2 layers. Okay, the side that would be this side right here. Okay, the one closest to the actual lung is called the what? Yeah, close enough. Yeah, visceral. You guys remember in pre and post-op when we're talking about evisceration, the intestines coming out, the organs coming out? So evisceration, the visceral is the one that's touching the organ or the lung. Okay, then you have the parietal. Parietal is on this side, the outer portion. Does that make sense? Now this is a little sheet, right? But there's a little space in between that sheet as well. Okay, you have some fluid in there that allows for lubrication to occur. So when your lungs expand and they compress on your heart, it allows for no friction to occur, so therefore there's no pain. Okay. The heart has the same thing. It's called the pericardium. When we get to third term, I'll be discussing that. Okay. What's the cutoff point? What separates the upper from the lower respiratory tract?
Trach.
No.
The larynx.
The larynx, yeah. The larynx. So the larynx, right? Let's pretend this is it, right? So the larynx looks funny. Okay. It looks like that. And you got some cords right here, and they vibrate every time we talk. Okay. Now, there's a flap that closes it. What's that called? Yeah, the epiglottis. So we have the epiglottis that actually serves as a little flap, and it closes it. What's the purpose of the epiglottis? You folks remember? The purpose of the epiglottis is to protect the airway. So it's what the part of the body that actually regulates that is the autonomic nervous system. I mean, whatever, it's involuntary. Okay, so whenever we swallow, okay, peristalsis takes the bolus, through the esophagus, but the flap, the epiglottis, it closes down and it protects your actual windpipe, okay, the larynx. What's the trachea made out of? Yeah, it's made out of cartilage, okay, and connective tissue. When we do a tracheotomy, when we get a little device, imagine the little rings right here, that's a cartilage, right? So we're gonna put a little cut right there and then insert the tube in there. Okay, and that's how we maintain something called an artificial airway. Okay, something I didn't talk about on Monday or Tuesday, I just forgot to talk about it, but I'll just talk about it on Monday. Patients who are ventilator dependent, they cannot expectorate on their own, right? They can't really cough things out, especially like if they're comatose. How do we get rid of secretions?
Suction?
Suction. Do you guys know the basic rules when we suction?
No.
Okay. Let's talk about it. Hold on. Alright, so that's a bad idea. So when we suction, folks, I'll write it down right here, okay? The first thing we do is we hyperoxygenate or hyperventilate. I'm just going to do a little arrow to increase O2, because I'm limited in space. But you want to hyperoxygenate. You want to hyperventilate, meaning if the patient's on a ventilator machine, that the machine's breathing for them completely dependently, what you're going to do is a little knob, a little button. You push the 100% O2. Now these devices turn off on their own after a couple of after like I think about a minute. They shut off because we don't want to increase the O2 to 100% for too long, because it's going to throw off the whole breathing mechanism, right? So the first thing we want to do when suctioning is want to increase O2. Okay, after that, what do we do? Yeah, you insert the catheter. So you want to insert catheter. Now, quick question. When you're inserting the catheter, you guys have a suction?
Yeah.
Kind of.
Okay, you did. Is this the first time you guys have done it? Okay, so it's scary, right?
Mm-hmm.
It's really scary because what's happening is, even though what's the diameter of the windpipe? Do you guys remember? Of the trachea? It's about 1 inch in diameter. Okay, it's about the width of the length of my thumb up to here. So it's about 1 inch. Okay, so you put a little tube in there. It blocks at least 1/4 of it. Okay, so you're actually the patient's going to go through an apneic episode, meaning no respirations, right? So the tube comes in. You start putting it in, and you put it in up until it stops, until you can no longer push it in. You reach the base of the bronchus, okay, which is this right here, and you feel it. You can't go in there anymore. While you're going in, you don't suction. Please remember that. While you're going in, you do not suction.
How long can they keep that in there? Because the patient, I think Alicia did it too. They started having like a...
The procedure is like 10 seconds.
10 seconds is a magical time frame we're going to use. It takes you about 1 second to 1.5 seconds to get the catheter in. Okay, unless you'll see this, guys, when you start working at different facilities or you get different types of trach sets. They'll get stuck before they even go inside, and you'll have to turn it around, and it takes experience for you guys to be able to handle it better and actually push it all the way in. But after you guys get done that, it takes about 1 second, 1.5 seconds to actually get the catheter in. Once you hit the base, guys, it shall take you no more than 10 seconds to suction out. That means it could be 2 seconds, or it could be up to 10 seconds, but no more than 10 seconds. That's the key rule. That's why we always increase the O2. So we hyperoxygenate or hyperventilate. These are all interchangeable terms. You insert catheter with no suctioning. The third thing you do is you press the suctioning device. Who was that? Oh, there are people? Okay. So you press, I don't know, oh, my phone's in there. It's on silent too. You press the suction device as you're pulling the catheter out. Okay, so as you're pulling the catheter out, you press the suction catheter no greater than 10 seconds. Again, that can mean 2 seconds, that can mean 10, but it cannot mean 11 seconds. It cannot mean 10.5 seconds. just between up to 10 seconds. You'll notice that most of these patients, guys, if they don't have very thick or very tenacious secretions, so one suctioning will probably do, but a lot of these patients, they don't, especially when they're sick, got pneumonia, they got all these different types of issues, their secretions are very thick, so you have to thin them out. Sometimes you can't.
We were sitting over there since 1 o'clock.
What do you want me to do about that?
No, I was thinking the class usually.
1:30, I said I was here since like 12, but 1:30.
No,
1:30.
I thought usually we do the classes over
I know, but today we're doing it here.
Okay.
I've only been here for how long, guys?
10 minutes?
Yeah, I was gonna say 3, but thank you, yeah. 10 minutes. Yeah, so anyway, so you increase suctioning, you insert catheter without suctioning, you increase oxygen, you insert the catheter with no suctioning, you take out the catheter by, while promoting suction, no more than 10 seconds, okay? You let the patient rest for a minute, okay, 1 minute rest. Okay, now this 1 minute rest period, guys, is very theoretical. Do people really wait a minute? No, sometimes they don't. But we want to make sure that we let them rest so the oxygenation level can go back up and they can catch their breath. Now, what's the best way to assess their O2 status while we're suctioning? How can we know if the patient's actually desaturating?
Redness.
Okay. Redness can mean a lot of things. Cyanosis,
Redness.
it's too late by then.
Ah,
They became cyanotic, that's too late. How can we know real quick? The SpO2 monitor, guys, which is a saturation pulse oximetry. Okay, the little device in the thing. That's a test question, so make sure you guys remember that. Okay. So again, ruling: you increase O2, you insert catheter without pressing suction. While you're removing the catheter, you press suction no more than 10 seconds. You let them rest for 1 minute. You perform this you can do it 3 times, a max of 3 times, no more than 3 times. Okay? Does that make sense? The reason why you don't want to continue to do it after 3 times is because it's going to irritate the patient's airway, and it might actually cause a bronchospasm. It can cause airway constriction. It can cause hypersecretions. It can cause a lot of things. Okay? Actually, it can even cause damage, like physical damage with the tubing. Some of these tubings, guys, that actually go inside, they sometimes they're a little pointy. Okay, sometimes they're a little pointy. Excuse me.
All right.
Sometimes they're a little pointy. They can actually scratch the inside of the trachea. Sometimes they're flat. Okay, and they get stuck on the actual part of the trachea as well, of suctioning. Sometimes they have little holes in them. Okay, and that actually gets attached to the wall of the trachea as well. So just keep those things, consider those things, okay, guys? But essentially, these are the rules for suction. Okay, no more than 3 times, no more than 10 seconds. Hyperoxygenate. That's not in the specific order. It's in this order. But any questions on suction?
So as you're taking out the catheter, that's when you suction?
Yeah. That's just, now some people suction while they're going in. It happens. And but if they remember, theoretically speaking, you're not supposed to suction on the way in because it's irritating the stomach. Excuse me, the trachea. You're also removing oxygen as you're going in. So remember I said not even 10.1 seconds, right?
No.
So how long does it take to go inside?
1.
1.5 seconds. So that makes it 11 seconds. We can't suction for more than 10 seconds. So that's the whole rule. Okay. Any questions on this? Okay. If a patient has, let's say, if a patient has rhinitis, what 2 things can cause rhinitis? Could be actually 3 things. Okay, it could be an allergic reaction. Okay, it could be bacterial. It could be viral. Okay, let's consider those 3 for any type of upper airway disease that we can, condition that we can have. Okay, you guys don't even have to really look at the book. What you guys have to know is this: if it's allergic reaction to anything, what do we do to get rid of the clinical manifestations? To get this patient better, if it's an allergic reaction. Okay, you can give antihistamines. What's the most basic way? Remember, guys, when we start non-medicated, least invasive, least medications, and then we move down the list. So first thing we can do is remove the allergen. Okay, that's a test question, so please make sure you guys know that. We can remove the allergen. Okay, if it's a bacterial, what can we do? Give antibiotics. If it's a viral infection, what do we do? Yeah, not antibiotics. Yeah, you treat the symptoms. You give palliative care. You treat if they're congested, you give decongestants. If they're running the nose, you give medications for that. If they're congested, you give, I think I said that already. And so on and so forth. Okay, guys? Let's talk about breath sounds real quick. If you guys want to follow along, it's on page 379. On the little box, it talks about different types of breath sounds. When you have sonorous breath sounds, guys, that can be accompanied with other breath sounds. So it could be like sonorous crackles. Okay, you got crackles, but it also sounds like you're snoring. Okay, that usually means that you got a lot amount of secretions in the back of your throat. Okay, when you have crackles, please know this, guys. When you have crackles, it means you have fluids in your lungs. It's bubbling, popping sensations. They say that it sounds like you're running hair through your fingers. Okay, I just cut my hair, so I can't do it anymore. But you guys can do that yourselves, and it really sounds like that. The finer the crackles get, the higher popping pitch that you hear, guys. It means there's more fluids. Remember that when it comes to crackles, you're going to hear them in the base of the lungs. Okay. Will you have crackles for asthma?
No.
You will not. Why would you have crackles for asthma?
Reason.
You're not going to have crackles because there is a little bit of hypersecretion of the mucus, but what's happening is constricting the airway. It's not so much like draining into the base of the lung and filling up with fluid. That's not what's happening. Yeah, with bronchitis or with asthma, you're going to have wheezing, high-pitched wheezing. Okay. For these patients that have crackles, are you going to hear it during inspiration or expiration?
Inspiration.
Yeah, inspiration. Okay, think about when you blow air into a cup of water or something. You're blowing in air, so that would be like we're breathing in because the air is going inside. That's how the bubbles occur. How about wheezing? Inspiration or expiration? Both.
It's both.
It could be both, depending on what disease process, but it can be both. And we're not discussing those just yet. But it can be both. Okay, it could be during inspiration and expiration. On children, you hear it a lot in the base of the lung, and you usually hear it during the end of expiration. I'm sorry, the end of inspiration or the end of expiration. At the end, so they go, and then, okay, like that. That usually with children, that's how much it is. And again, we're going to go through this, guys, when we get to term 4, and we go over peds. Okay, pediatrics and all that good stuff. If you guys want, you guys can read up on like fine, medium, and coarse crackles. Essentially, it's the same thing though. Okay. Plural friction rub. What's the pleura again? Yeah, it's outside the lungs. So what do you think? When are you going to hear this? When you're breathing in, right? So essentially, when you're breathing in, they expand, and that's when the pleural friction rub occurs. It sounds like a leathery, like if you have leather and you're kind of rubbing your hand through it. It kind of sounds like that, kind of like a grunting noise almost. So if we identify the pleura being on the outer parts of the lungs, are we going to be assessing like right in the middle, the nipple area? No. We're going to be assessing towards the apex, on the sides. Okay, that's what we're going to be assessing for your pleural friction rub. You also have something called your pericardial friction rub. We won't discuss it now, but just don't get them confused because they might ask you, like on the question, which of the following will you see in pleurisy? We know the pleura is for the lungs. The pericardium is for the heart. So if it says pleural friction rub and then pericardial friction rub, it's not pericardial. We're not talking about the heart. Okay? All right, let's see. What part of the brain controls the respiratory regulation? The medulla oblongata. Okay. What happens if, again, what are your, if your CO2 is 50, are you acidic or alkalinic?
Acidic.
You're acidic because CO2 equals acid. So if you have high amounts of acid or high amounts of CO2, it's going to be acidic. What if you have an HCO3 or a bicarb of 30? Alkalinic, because the HCO3 or the bicarb equals alkalinity, right? Okay. What happens if your pH is 7.16? Hmm?
Normal now.
No.
It's normal. Yeah, it's normal. What if here, I'm gonna tell you guys something real quick. What if your pH is 7.16, your CO2 is 40, and your HCO3 is 41? I know you guys probably won't get this right now. I haven't taught it yet, but this is called compensation. But let's identify each of them first of all. What's the pH? Is it acidic or is it alkaline? Acidic, right? We just talked about it. Yeah, 7.16 is acidic, right? So the pH, when they take our blood, the pH is 7.16. It's low, so it's acidic. Okay. The CO2 is 40, though. What does that mean? What does that mean? Don't be scared, guys. It's okay. Yeah, it's normal. It's normal. So you're like, man, but how is it? But then look at the HCO3. It's 41. Is that high or low? Remember, 22 to 26.
Oh, high.
So it's very high, right? So look, when you guys see this, I'm going to teach this in next week, I think, or the week after that. This is called compensation. It means that the pH is still low, okay? It's still acidic, but the CO2 is normal now, okay? But it's still acidic because the HCO3 has been going up. So it compensated, which means it regulated the CO2, but it's still acidic. There's still an underlying issue, but the HCO3 is high, meaning it's trying to increase the alkalinity so it can decrease the acidity. Does that make sense? So it's called compensation. Okay, we can tell it's compensation because if this is alkaline, if you have more alkaline, it's going to overtake the acidity, right? So it's trying to compensate, and it regulated the CO2, but the actual pH is still abnormal because there's some underlying condition. But we're going to be discussing this in about 2 weeks or a week or so. So just keep that in mind. Okay, but what you guys answered at first, that's what you guys have to know. All right, what happens if you have pulmonary edema? What does pulmonary edema mean? We haven't even discussed this yet, but what happens? What does pulmonary edema mean? Fluid in the lungs. What happens if you have that fluid in the lungs? Okay, if you're standing up, where are they at? Where's the fluid? In the base, right? If you lie flat, where's the fluid at? Yeah, everywhere else, right? So are you going to be able to breathe well? Is there going to be oxygen exchange? There's not. What's that called when you lie flat and you can't breathe? Orthopnea. Okay, please know that word, orthopnea. Please know that word, orthopnea. Okay. If we have a patient that is that has a pleurisy, meaning the pleura is inflamed, you have fluid in there. You now have something called empyema, which we'll discuss later. But these are words that you still need to know because I might ask you a scenario that has the word empyema, but I'm only going to be asking you about a thoracentesis. So my question to you guys is this. The patient now has empyema, which is just the fluid, the infected fluid in the pleura, okay? And the patient's going to have a thoracentesis. What position are you going to put them in?
Sitting up.
Sitting up position, right? That's the illustration that you guys saw yesterday in the PowerPoint, right? How much fluid are you going to be taking out? No more than 1,300 in how long? 30 minutes. Okay, so remember that, okay? No more than up to 1,300, no more than 1,300 in 30 minutes. Okay. One more thing about CO2 and the CO2. Do the lungs or do the kidneys regulate that? The CO2. The lungs. How about the bicarb, the HCO3?
Kidney.
The kidneys. Okay, I want you guys to remember that as well. How do we control nosebleed? You pinch. Exactly. The cartilage part, and you lean forward. What happens if a patient has just had a tonsillectomy, and they just came back from surgery, and they look good, and like, how you doing then? And they keep swallowing. What does that usually indicate?
Bleeding.
What are you going to assess to see if they're actually bleeding? I'm looking for, blood pressure, yeah. Because we can see if they've been bleeding for a long time, they're going to start becoming hypotensive. You also want to have them open their mouth, look inside if you can see the postnasal drip of blood and things like that. But blood pressure is key. Blood pressure is key. If a patient does have epistaxis, nosebleed, and notice I'm jumping from topic to topic, but just bear with me. If a patient does have epistaxis, okay, and you've tried packing it for like 30 minutes and it's still bleeding, you try compressing it, putting it in ice, it's still bleeding, and the doctor orders epinephrine. What's the rationale behind ordering epinephrine for epistaxis? Speak up, I can't hear you.
So you're getting injected through the nose?
Yeah, but what's the rationale behind it though? Why do we want to do it? Why is he doing this?
To
Yeah, to promote vasoconstriction. What ends up happening, guys, with epinephrine, I'll give you guys, let's see if you guys could remember like this. What happens during an anaphylactic attack, meaning an allergic reaction? You guys remember? What happens to the blood vessels? They dilate. That's the issue about an anaphylactic reaction. So like if you ingest something you're allergic to, your blood vessels dilate. So your blood, it tends to pool. It's not pumping. So your blood pressure drops and you pass out. Okay. You guys ever hear the EpiPen? Okay, for an allergic reaction, sometimes people have something called an EpiPen. It's a pen that has a little needle on it, and it's a disposable. Kind of like an insulin pen, but it's called an EpiPen, and you inject it to yourself, and it gives you epinephrine, and that's supposed to reverse the effects of an anaphylactic reaction, right? Because it's going to constrict your blood vessels. EpiPen, remember. So the same thing happens during while we're bleeding, epistaxis. We give epinephrine locally, okay, and it constricts the blood vessels, which aids in the hemorrhage cessation. Does that make sense? So please know that. Please know how many units we give. It says on page 385, under medical management, epistaxis has many possible treatments, including nasal packing with cotton saturated with 1 to 1,000 epinephrine to promote vasoconstriction. Okay, that's the unit that we use to know how much the quantity. So it's 1 for every 1,000. Any questions? If you guys have your book, go to page 384. It says under like the middle of that section on the left side. So let's see, right here. Okay, I'm gonna start reading so you guys can know exactly where I'm at. It says an SO2 of 90% to 100 is needed to adequately replenish oxygen in plasma. Meaning that's how much we need in the blood. Okay, we need 90 to 100% when we do the SpO2 monitoring. The ability of hemoglobin to feed oxygen to the plasma weakens significantly when the SaO2 drops below 85%. So once it drops below 85%, that's when we're going to start to see the manifestations of some type of ischemia, some type of oxygen deprivation. And then it says an SaO2 of less than 70% is considered life-threatening. You guys have to know those parameters. If I tell you guys that the patient has an oxygenation level of 89, what are you going to do? Yeah, I'll probably call the doctor, tell them, hey, look, it's 89. Is it an emergency yet? No. Can the patient still sustain himself with 89%? Yeah, but we want to kind of get it moving a little bit. What if it's 66? Medical emergency. Yeah, you always want to raise the bed as well. If it's like an 89, you want to raise the bed. What does raising the bed do? Fowler's position. What does that do? Yeah. Yeah, it allows. So what I want you guys, it does all those things, but the way that it does it is allows lung expansion, maximum lung expansion. Okay. You guys ever been sitting down for not for a long time, but just sat down abruptly, tried to take a deep breath? It feels like it's a little constricting. Or am I the only chubby one here? But essentially that's what it feels. So that's why you have them sit up, so it can maximize their lung expansion. Okay, I think I talked about a lot of good stuff. All right, let's go for the basic review. Will you guys be here Friday by any chance?
Are you going to be here?
Yeah, I'll be here Friday.
I'll be here.
All right, so is it recording? Okay, that's good. Alright, so again, what happens if you're auscultating a patient's breath sounds and you can't hear them? What do you have them do? Yeah, take a deep breath, okay? Mr. Jason, you said the reason to put a patient in Fowler's is for what? Yeah, it promotes lung expansion. Alright. What medications increase risks for bleeding? Okay, vitamin K actually reverses the effects of anticoagulants, so it actually helps clot. Yeah. Blood thinners, warfarin, Coumadin. How about aspirin? How about NSAIDs? Yeah. Okay. I talked about this. I'm sorry. When we're doing pre and post-op, okay, how can we prevent atelectasis? Coughing, deep breathing. What else? What? Incentive spirometer. Incentive spirometer, folks, is one of those things that you guys have to memorize forever. Like if I call you at 3 in the morning, I'm like, hey, what do you use for pre or post-op? Incentive spirometer. You have to know like that. Okay, because we're going to be testing on that a lot. What happens if a patient has just had some type of craniotomy and they're just post-op? What type of breathing exercises are you not going to recommend?
Deep breathing.
Deep breathing, coughing, all that stuff. You don't want to increase intracranial pressure. What position are you going to put him in? You're going to put him in Trendelenburg?
No.
Oh, what position? They just had a craniotomy.
Reverse.
Semi-Fowler's position. Like 30 degrees, okay, guys? A semi-Fowler's position because you want to decrease the pressure in the head. I'm throwing questions like from different angles, folks. So focus on what I'm trying to say here. What's hyperventilation? What does that mean?
Breathing fast.
Breathing fast, right? I think I showed you guys. I got a little dizzy. Okay. What does a moment of apnea mean? Not breathing, right? So it's like if we're thinking that the breathing are like those little graphs, a moment of apnea is flatline, right? You guys remember what Shane Stokes are? Shane Stokes breathing? Yeah, it goes fast, slows down, apnea, slows down, speeds up, slows down. Like that earthquake we had that one day in class. There was no earthquake that day, by the way. No, there was an earthquake on Monday, not on Tuesday. You guys are crazy. Anyway. What did I say about you guys know what I've talked about this before, a metereddose inhaler? You folks remember that? From A&P? No? Okay. Wait. Metereddose inhaler, MDI. Okay, well, a metereddose inhaler is those new nebulizers, folks. It doesn't look like a regular. No, it doesn't look like a regular inhaler. It looks like you know those old school gum, the little plastic, the pink ones that they're wrapped around, and they have like a little. It looks like a mascara or makeup. Compact. Yeah, I don't know. So yeah. Anyway, it looks like that. Okay, it's called a metereddose because you bring down the latch and it's already regulated how much you're gonna receive. And you usually put it close to your mouth and you take one of them. The thing about these metered doses, guys, is that it's supposed to relieve decongestion. It's supposed to expand your bronchus. The problem is that if you use it excessively, it can cause rebound congestion. That's the main issue. And I'll talk about that more on Monday, but that's the main issue with metered dose inhalers. That if you take too much of it, it can actually make the signs and symptoms a lot worse. Okay, does that make sense? Okay. What's the best way to avoid catching the flu? Hand washing is above that, but yeah, that's a flu shot's good too. Yeah, a flu shot's good too. You can take get a flu shot. Hand washing is the best way, guys, to actually minimize any transmission of any infectious agents. You know that this season we had the highest mortality rate for the flu?
Miss Francis told us.
Yeah. Have you guys heard it in the news yet? They don't talk about it, right? I'm like, what the hell? My buddy called me like a month ago. He's like, dude, 3 guys died this week, all under 40 years of age. Yeah, I didn't get the flu shot. I forget that. All right. Yes. Okay. When it comes to chest tubes, okay, real quick on chest tubes. What do you think the chest tube has to be? Above your waist level, under your waist level, on your waist level, behind your waist level? You guys ever seen a chest tube with a drainage compartment? Oh, I'm sorry.
When you do the nose waist thing,
Huh?
so that when it drains out, it goes down.
Yeah, it's gotta be below your waist level. Okay, on page 409. I know we didn't get that far, but it asks a basic question about this. Okay. If you read up on it, it'll tell you. But essentially, folks, the chest drainage tube is when you have fluid inside the actual lung, not the parietal set, not the pleura, but when you have it actually inside the lung, that it's probably even pushed the actual lung to the side. So you insert a chest tube and you monitor drainage. Okay. Usually it's supposed to be below the waistline, so it can actually gravity will actually guide the fluid down there. Okay. What do we do before we suction? We hyperoxygenate. We increase the O2 level. What happens if my CO2 level is 68? What does that mean? Hmm? What? It's life-threatening. I'm sorry. Yeah. I thought left Trendelenburg. I'm like, what? Yeah, the CO2 level's high. Is it acidic or alkalinic? Acidic, guys. Remember, CO2 equals acid. CO2 is acid. So the CO2 is high, it's alkalinic, right? Yeah, it's a medical emergency, essentially. You need to notify the doctor. If your CO2 level is low, let's say it's 12, significantly low, how can you increase it? How can you make it higher? Remember the bad guys? Okay, every time we breathe, okay, so I'm breathing right now, right? Every time I breathe out, CO2 is being blown off. So like, breathe faster, I'm blowing off more CO2, right? So as I hold my breath, though, the CO2 builds up in higher quantities. Okay, so if I'm breathing fast, I'm blowing off CO2, my CO2 level is 12, what can I do to make sure that that level goes higher? People that, you can hold your breath, that could usually work. But people are, when they're experiencing hyperventilation, you can't just tell them to not breathe because they're going to pass out. You give them a bag and you have them breathe into it, because that's the main issue. They can't stop breathing fast because they think they're going to die. And it's happened to me before. I literally thought I was going to die. I'm like, today I'm dying. That's it. No kids, no nothing. This happened 5 years ago. So, yeah. So make sure you have them breathe into a bag, because like that you're recycling that CO2. That CO2 is, you're breathing it back in, and it's really good. Try doing that, guys, when you're normal. See what happens. You're going to get lightheaded. You're going to pass out. Okay? Also remember this. I talked about this yesterday, I think. The higher the CO2 level goes, your blood vessels in your brain, they dilate. Okay? That's important to remember for something we're going to talk about next week. Okay? So as your CO2 levels increase, the blood vessels in your brain, they dilate. Give me a value, a numeric value of a heart rate if they're bradycardic. Okay. Okay, 50. That'll do. Yeah, 59 would do. Anything below 60. How about if they're tachycardic? 101 could be it. 120 is it. That's fine too. What if a patient is tachypnic? Give me a number for respirations. Tachypnic.
25.
25. Okay, that's theoretically speaking, that's high. Bradypnea. 10. Okay. Anything below 12. You guys remember the level? 12 to 20 for respirations and 60 to 100 for heart rate. Okay, good. Why do we have a patient lean forward while they're having epistaxis and we're constricting the nostrils? Why do we do that? Okay. Why else? Yeah, so it could clot. Okay, essentially, yeah, you do this, it's going to keep going in your stomach, it's going to irritate it. But the whole purpose is like, we make sure that the blood is pooling in that particular pocket right here, and it clots. Okay, now, if your patient has spontaneous epistaxis all the time, what are you going to assess to see if they're susceptible to bleeding? What are you going to be assessing? Think about it really hard. What are you going to be assessing? Okay, if they're anemic, CBC, you're on the right track. Keep going. What else? If they're taking Coumadin or warfarin, now listen to history of medications, and if the patient speaks some other language, like I said, I think, was it to you guys?
Yeah.
So what is it?
History.
Yeah, but PTINR. Yeah, it was more. Yeah, yesterday you guys were on the right track. Yeah, the PTT for the heparin or the PTINR for the Coumadin. You want to assess lab values. That's when you said CBC. I'm like, yes. Yeah, PT is prothrombin time, and INR is international ratio. PTT is partial thrombin time. PTT, and that's for heparin. Okay, let's do it one more time. PT/INR, PT/INR. PT/INR is combined, and then you have PTT, which is for heparin. The PT/INR is for Coumadin. The PTT is for heparin. Okay.
And then the third one was 8.
Huh?
Never mind.
I'm sorry.
I'm just asking a question.
No, that's fine. Yeah. But the H for what though? With the H for what?
Never mind.
Okay. I'm not going off the book anymore. Please know the definitions, guys, to vital capacity. Write this down. That's in your book. I forget what part, but it's in your book. It's one of the. I actually read them to you guys. Vital capacity, your your tidal volume. What page? 380. Where?
Great.
Oh yeah, right there. Pulmonary function test, yeah. Okay. Okay, so yeah, know the inspiratory capacity, the total lung capacity, the vital capacity. Okay. There's another page where it gives you more detail. Hold on. Okay, I can't find it, but I'll find it. Remember the signs and symptoms of your sinusitis, guys, okay? Sinusitis. inflammation of the sinuses, not the nares, okay, guys? These are the sinuses that we have on both sides of the face. What are the rules when it comes to taking antibiotics? Okay. After we're taking them already, though, what's the rule?
Finish them.
Not on an empty stomach. Continue them until they're done.
Yeah.
Usually the patient starts feeling better about 2 to 3 days on average after they start the intake of antibiotics. And a lot of times the people just stop taking them.
Mm-hmm.
But why do we not want to advise on that?
Because even if the symptoms are gone, you might be there.
Both of you guys are right. Some might be there, you guys said the same thing. Yeah. Also, you may develop a super strain. Okay, the organism might get accustomed to this particular antibiotic, and they become another MRSA. Okay, that's what MRSA is, by the way. It's a bacteria. It can't be killed off by your regular antibiotics. What's the difference between dysphagia and dysphagia?
One is a speaking and one is swallowing.
Yeah, the G, gastric, swallowing, because it goes into the stomach, and the S is for speaking. Okay, this is difficulty, right? Okay. I spoke about tonsillectomies yesterday. What type of foods can we eat? Ice cream, cold stuff, yeah, cold stuff. After every surgery, any surgery, what do we assess before we give PO? Gag reflex, yeah. How long can we suction for? No more than 10 seconds. Yeah, no more than 10 seconds. That means it could be 1 second, 2 seconds, 3 seconds, all the way up to 10, but no more than 10.
But does the one where we're inserting the catheter
count?
Yeah.
No, that doesn't count. I was talking about, before some of you guys came, that it takes about a second or a second and a half to actually insert the catheter to the base of the lung, and then we suction for no more than 10 seconds. What we're counting is the suctioning part.
No one for the trach.
Yeah, for the trach suction, yeah, deep suction, yeah. What are antimicrobial agents? Against what? Against microorganisms, yeah, infection. But this isn't a virus. Okay, antimicrobials are also, it's like when we take our the hand sanitizer, yeah, they have antimicrobial agents. Okay, good. And remember, folks, we use to get rid of viruses or to treat viruses. We can't get rid of the virus. We just treat the signs and symptoms. To get rid of the bacterial infection, we use antibiotics to get rid of the organism. What happens if a patient has very thick sputum or thick secretions? How can we thin them out? Give them water. Give them water. Water. Remember, guys, every time we're addressing these patients, unless it tells you which medical intervention you're going to use, you want to go for the non-invasive, non-medications, because we start off with that first. We start off with whatever's non-medicated, because we don't want to just dope them up all the time, right? And then as we, theoretically speaking, okay, guys? When you guys get to the field, it's a little different. But theoretically speaking, that's what we do. What do I mean by a patient using their accessory muscles and nasal flaring? What does that usually mean? To breathe. Yeah, they're having trouble breathing. So like if I feel like I can't catch my breath, so I'm going to start, and so you'll see all my muscles in my neck pull up. I try to pull up my chest, and my nostrils are going to be flaring. They're going to try to get open because you're like gasping, you're hungry for air. Okay, so that's what that refers to. What's the fastest way to monitor an oxygen saturation level? SpO2. What do I mean by expectorate? To cough up. Yeah, to cough up. Yeah, to cough up. To cough up. So expectorating, guys. Or also, you'll have like an expectorant, which is now a medication that causes you to, you guys heard of mucomist? Okay. Mucinix, not mucomist, Mucinix. Pay close attention, folks, to the questions when they ask you most effective or least effective. So if I say least effective, which one of these is not going to work on whatever they're saying? Most effective is which one of these is going to be best for this condition. What's the purpose? I talked about an oxygen saturation level of 89, right? Or like 88. We said from 85 and on, now we're not getting enough oxygen throughout our tissues, right? But if I say 86, 87, 88, 89, that's still below the 90, but is a patient still, theoretically speaking, can they still transport oxygen to the tissue? Yes. Yeah, so we agreed that we would call a physician, right? What's the purpose of calling the physician? To give O2, not CO2.
O2,
yeah, to get an order, to get an order for the oxygen. Okay, we understand that. All right, good. If I say I have a stat order, what does that mean? Stat. Immediately. It means right now. Okay. After a bronchoscopy or a laryngoscopy or a any of those, when can I offer fluids? When gag reflex returns. And what do we use to assess gag reflex? Tongue depressors. Again, if I'm breathing really fast, what's happening to my CO2? It's going down. It's going down. It's going down. Getting rid of it. Because remember, every time I breathe out, I'm blowing it off. Okay? The slower I breathe, the more time I have for that CO2 to build up. All right? How do we know a patient needs suctioning? Phlegm. Yeah, if you hear crackles, wet sounds, okay? A lot of times, folks, you can hear them without even auscultating. Even when they talk, they go, "Hey, how you do?" And they're gurgling in their secretions. It's really bad, folks. And really, the nurses are the only advocates, because sometimes the respiratory therapists, they're not that they're bad or anything, but they're up in they're changing a trach or they're doing something very important, you know. They're administering their own breathing treatments. All the RTs I know smoke. All of them. It's funny. It's very ironic. Anyway, so yeah, you want to make sure that we suction, okay, guys? Have all of you guys had a chance to suction yet? Okay, if you have not, make sure that you bug them, hey, let me suction, man, let me suction, let me get in there, because you need to know how to do that. You need to know how to suction.
I did.
Yeah.
That's not something I wanted to do.
Yeah. Sometimes it's really bad and it smells really bad. Sometimes there's maggots in there.
No, there's
Really bad. Really bad.
And you should wear
30
goggles.
years. It was really bad.
Was it a closed trach or was it just a stoma?
There's a stoma.
Oh, just the tube's coming out though, right, with the little strap?
Yeah.
Okay, some patients just have the stoma, and when you suction, they might gag and they sometimes throw up.
Suction
It
her
was
very
crazy
often.
that when we first started, they didn't have a suction order for her. Our instructor had to intervene and get a suction, and then they didn't know how to even do it. The other nurses that were there, so it was really bad. It was kind of has an odor, so I think it's kind of infected. It's really
Probably. I said there's sometimes maggots, not sometimes, but I mean, I've actually seen maggots in the patient's trach. Because it got very infected and the flies fly around, they lay their eggs and they get maggots. It's bad. Yeah. And this patient was a closed unit. The closed unit, even the catheter is surrounded with plastic. Yeah, and the maggots were in the plastic. It's been there for a while. It's really bad. That's a big lawsuit. If a patient's no. What happened? She got scared? That's funny. I got scared last week. There's like a garage door right here that they open and close all the time. Man. Let's see. Okay. I talked about tonsillectomy, right? Patient keeps swallowing. It might indicate some bleeding. Any type of surgery, guys, that involves the nose or the throat, okay, will indicate that. So tonsillectomy, adenoidectomy, nasal septum reconstruction. You guys remember the deviated septum or the polyps? Anything like that? It might indicate the same thing. If the patient's okay. What medication will you really be careful when you give regarding the respiratory system? Opioids. Which one in particular? Morphine. Morphine, folks. It's morphine. Write that down. Make sure you guys know that. Morphine depresses the respiratory center of the brain. Do we know what to give if we give too much? What's that medication? You guys remember? Starts with an N. Norcan. Yeah, Norcan. It's Norcan. I don't think I test you on that, but you guys need to know that. That's like NCLEX stuff. So again, fluids in the lungs. What what adventitious sounds are we going to hear? Yeah. How about asthma? Wheezing. Okay, good. What adventitious breath sounds are we going to hear if a patient has sleep apnea? Snoring. That's right, snoring. Have you guys read at all or practiced applying the SpO2 monitor to the patients? Yes. What will cause an abnormal reading, aside from an abnormal respiration? If the patient, if they're wearing like really dark nail polish, it won't work. If they keep moving around, it won't work. Yeah. Excuse me? That's right. Also, a lot of people don't notice that they put it on, it's not plugged in. Because the things are really cheap at convalescent homes, right? If they're not plugged in. Also, guys, as soon as it drops below, I think 94 or something like that, or no, 90 probably, it starts beeping and it's really annoying. Make sure you guys don't just go put silent while you're with the patient, you know what I mean? But make sure that they're okay once you leave, because a lot of times we just go, oh yeah, what's up? We just put silence and walk out. You don't want to do that. Okay?
So it doesn't matter if the sensor, you put it on top of the nail?
Well, it's supposed to, the beam of the light is supposed to go on top of the nail. Okay? You can't put it upside down. It'll work. You've been doing it the other way, huh? Now that's what, it has a little illustration on, okay. Yeah. The light of the beam actually has to go into the top of the nail. Okay? But if you put it underneath, it can work as well. Because all it is, it's going through the tissue, so it can actually see, or the nail, so it can see how much hemoglobin is wrapped around your RBCs. Okay? Or how much oxygen, excuse me. If I'm going to do a throat culture, okay, culture of the throat, what do I need? A swab, right? Probably a tongue depressor, very basic. If I need a sputum sample, what do I need? A specimen cup. Okay, it's got to be sterile. They open it themselves, okay? Good. When we obtain a sputum specimen, is it, I almost spit for real there. Is it like a spit, or is it from your lungs, or from your throat, or from where? Yeah, from the base. Try to go like Leo DiCaprio and that one chick in that one movie, okay? You know what I'm talking about. Kate Winslet in Titanic, yeah. Kate Winslet, right?
Yeah.
Yeah. You guys see her in Enemy at the Gates? Wait, is it Enemy at the Gates?
I didn't watch it.
It's a good movie. Gotta watch it tonight. Not tonight, but watch it. It's a good movie. Let's see.
Along with Departed.
Departed, yes, that's the best movie ever. I'm gonna go see that tonight. You guys know what Hulu is? No, not Hulu. Voodoo. It's like on demand. You can rent them, or you can buy them. It's called Voodoo. Hulu is another one, but this is Hulu's like Netflix. This one you have to pay for right then and there.
Really?
Yeah, you can see them like after the movies come out in the theater, like a week or two later, they're there.
Or Apple TV.
On Voodoo. Apple TV does the same thing? Sounds expensive. Apple TV.
It's not.
It's not? Okay, but it's good stuff. It's good stuff. If I didn't have a job, I had no reason to leave the house. I'm just like, everything's there. Let's see. Again, we talked about epinephrine. We talked about positions for treating epistaxis. We talked about breath sounds when there's fluid in the lungs versus constriction of the airway. Understand this, guys. When you have asthma, you're wheezing also because there's a hypersecretion of mucus. So it also, the mucus itself, it narrows the airway. So that's what you hear. Okay? Let's see. If a patient has, you guys ever been short of breath? What happens every time we walk up those damn stairs? You get out of breath, right? We're horrible. I'm out of breath every single time. That's why it takes me a second to talk to you guys. I'm like, hold on. Do you guys know what I usually do? If I have to talk to you guys immediately, this is what I usually do. I take a deep breath, and while I'm exhaling, I'm talking to you guys like right now. Now, it doesn't sound like if I was short of breath because slowly my air's coming out, right? And this is what you actually do. So this is what you have the patient do. Except for them talking, you have them do exactly what I'm doing right now. See, I'm done. But you have them breathe out with pursed lips because it slows down the exhalation and it regulates the CO2, O2 level. So if somebody's dyspneic, short of breath, you have them take a deep breath. It actually helps them out. Okay? Pursed lip breathing. It's called pursed lip breathing. Okay? Okay. Is there mucus in the sinus?
Yes.
Yeah. So if you have sinusitis, what's inflamed? Yeah, the mucal membrane, okay, the membrane inside, okay, that's all inflamed. Remember where it's at, folks. So you'll also have excessive tearing, you'll have rhinitis, meaning runny nose, you'll have all those things, okay? What did I say about anytime any alarm goes off, what do you do first? Assess. You assess the patient. You assess the patient. After you assess the patient's cool, what do? It's still alarming. What do? Check the tubing. Check the tubing. The tubing could be off, guys. It happens all the time. How can we tell a patient's breathing better? What's the most effective way? That the patient. Okay, what else? What'd you say, Alicia?
Smiling.
Okay, it's getting closer, yeah. Essentially, they tell you, hey, look, I don't have any shortness of breath anymore. I feel like I'm breathing a lot better. That's.
Really?
I mean, I know, I explain this a lot, guys, is because I know it's very basic, and I know you're like, nah, that can't be it. That's not it. But essentially, that's what's going to happen. Yeah, or whatever how do you tell a patient? Remember, we go back to pain management. How do we know the patient's pain is relieved?
By asking.
Yeah, by asking them. If they verbalize to you, yeah, I have no more pain. Okay? Hey, Ms. Lawyer. Okay. There's also 2 extra credit questions on the exam, by the way, okay? If I were you guys, I would read ahead a little bit and know what... Where is it? Page 411. Know what a pneumothorax is, okay? Know what a pneumothorax is. I talked about it when I did head-to-toe assessments with you guys. It was a long time ago. We won't be discussing that till next week, but extra credit points. Know a little bit about pneumothorax. Ms. Gloria, you want to tell them what a pneumothorax is? Oh, that's horrible. You should from other class. You guys have any questions?
Is there any mask?
I'm gonna throw some math in there, yeah.
Can you throw like 10?
Like 10.
No, 5.